will be answered. And now I'm going to introduce Dr. Treasure. Professor Janet Treasure is a world-leading clinical and academic psychiatrist in eating disorders who works at King's College London and the South London and Maudsley Hospital. She was awarded the OBE for her work on eating disorders. Dr. Treasure is a fellow of the Academy of Eating Disorders, the AED, and associate editor of European Eating Disorders Review. She is co-chair of the Eating Disorders section of the European Psychiatric Association and leads a European study on the value of treatment. Professor Treasure has been a principal investigator on several multi-center studies in eating disorders and a co-investigator on many international studies. She has mentored over 60 PhD students and numerous clinicians. Professor Treasure has written numerous books on eating disorders. In particular, she has co-written books and other materials with people with lived experience. She has pioneered a collaborative approach of working with patients and their families on treatment, intervention, and sciences. I just remember that I forgot to introduce myself. I'm sorry. I'm Judy Krasna. I'm the Executive Director of F.E.A.S.T. I'm really happy to have all of you here with us today, and it's my honor to introduce Professor Treasure.
Thank you. I think you need to switch. Oh, yeah. Hope you've got your slides and you can see them. Is that right? Yeah. Good. Well, I'm very pleased to be able to be joining you this evening to be talking about work we've been doing over many years, co-working, as Judy said, with people with lived experience, which has been so helpful. So what skills are needed? Well, these are some of them. Providing support to moderate risk factors, working to help someone who doesn't think they've got a problem, understanding how starvation can have a problem on social functioning for the individual, and understanding how an eating disorder can have a problem for supporters. So what about providing support to moderate risk factors? Well, we've had this amazing natural experiment with COVID, in which we've seen this very huge rise in the incidence of eating disorders across the world. And so that suggests that there's been something in the environment that has triggered the disorder. And when we think about it, it does fit with all the work we've done before. And if you look at this quote, which is a personal journey of somebody who had eating disorder when she was in her early teens and then recovered and trained in medicine and wrote her personal journey for the BMJ. But she said that the one word that would characterize her disorder was isolation. And of course, with COVID, we had isolation. And these slides here and these quotes add to this. And I need to acknowledge Elise Warrener, who has contributed a lot of the artwork to this talk today, and she's somebody who's had an eating disorder, and you can see her explanation of one of her paintings, Blue, that there the red's the world outside, and she's in this cold ice cube with an empty stomach and a bandage, sort of with silent suffering. And then Melissa saying it's the loneliness that gets you, it's the real killer, and the longer you have it, the worse it is. And so as supporters, we can feel rather like being in this picture by Elise, sort of blocked out with a wall and a sort of a raging problem below. And it's very difficult to know what to do. But the things that are very important are to break down this isolation. It's to offer love and compassion and empathy, to hold the hope, and try and overcome the self-isolation barriers and the fragmentation that occurs. But we know that with COVID, it probably wasn't just isolation, and there were several other things that were going on that really echo uh, longitudinal studies suggesting that other things are risk factors. So we know that screen time can be very important, and especially when that's the only source of information and not buffered by social forces. But also we know that fat talk and weight stigma are important. So we had the quarantine 19, all the chat about weight gain, and also the chat about people unfortunately having to go to ITU, and those were in larger bodies did less well. So there's several things that we perhaps need to think about and make sure that we can have an environment where these things don't play such a big role. So the next step is to try and think, how can you help someone who doesn't think there's a problem? This can be very hard. This statement by a French psychiatrist in 1850 sort of characterizes this problem. You know, people said that people just said, "I don't suffer, therefore I'm well." And one thing that perhaps could explain this is that the new genetics findings that I've outlined to the right, that are very exciting and interesting, uh, perhaps indicate that there may be an atypical response to starvation, because what you can see in the purple are a profile of metabolic uh, traits that are unusual. And so it may be this unusual metabolic profile that makes people less sensitive to weight loss and perhaps less able to regulate it, or less seeing of symptoms. Oh, so I've gone backwards. But another thing is that there may be a clash of agendas. So often aspects of anorexia are valued, and this is a scribble drawing made by a patient on an inpatient unit for us, explaining, you can see how there is a little person under this big ball of fear, and the anorexia is propping the fear away from her, so she feels safe but trapped. And the fears are several. Mm. Oh, I can't go to the next slide. Why can't I go to the next slide? And this next statement shows how people do have this ambivalence about giving away aspects of themselves because they want to keep the illness as a coping mechanism and keep it rather as a secret. Maybe whilst we're talking, you might think yourself about what other things might be valued about an eating disorder and perhaps put them in the chat. I think a comment probably doesn't work with a large group. But this other picture just again gives us more ideas about some of the nice and nasty aspects of eating disorders. So we can see it can be a refuge, feeling safe, a sense of identity, but then it's lonely, full of lies, failure, hurt, and fear. And so to try and help somebody sort of stuck in this dilemma of seeing value from the eating disorder and maybe not noticing some of the negative aspects is very difficult. But this image of from Aesop's fables gives us some way of thinking about how we need to approach this. So we can take an approach where with a cold north wind and try this to blow the man's coat off, but we just find that they'll wrap up the coat even tighter. Whereas if we have a warm, kind, gentle approach, such as the sun, the man would take his coat off himself. So this is the sort of thing that gives you the sort of style of interaction that we teach therapists and families too, that may produce most benefit. And some of the techniques that we find particularly important are emotional coaching. So to be able to pick up emotions and manage them. And so the work of Joanne Delahanty from Toronto, who was taught by Greenberg on emotional focus therapy, is particularly helpful. And there's a little saying that you need to be able to attend and to label and to validate and soothe. I always find that one a bit hard to remember, whereas the see it, say it, spell it, and soothe it perhaps is a bit easier for me anyway. So you're trying to attend and notice what the emotion is, and you might be getting micro emotions because, as I'll tell you later, emotional expression is reduced. Then you need to take a stab at uh, thinking about what the emotion is, because we know that people with eating disorders often have difficulty in recognizing what the emotion is. They that's a problem. And then you might be able to validate that emotion by trying to sort of indicate where the emotion may come from. You know, you're upset because you wanted to go to your friend's house, but that wasn't possible because of, whatever. And then offer to soothe the need. That emotion signals that perhaps I should, as a parent, you can give a hug. We can't do that as much in therapy. So learning how to be a very expert emotional coach is very important. Then the other technique that we teach all our staff and also parents too are the skills of motivational interviewing. And this is a technique that has been developed specifically for people who don't want to change, who don't see that there's a problem. It was developed initially for alcohol problems. And it's a style which tries to strengthen the person's own motivation and commitment to change and allows them to think about their own personal values, their capacities and strengths, and develop their own reasons to change over time. And so that's your aim. And you use relational aspects with empathy and respect for their autonomy. But also there are technical elements that help build change talk, build the motivation to change. And these are open questions and affirmations. I can't obviously go into all of this, but I'd highly recommend reading the book on motivational interviewing by the developers Miller and Rolnick, and there's many editions of it, and it's worldwide of value. So these show my age a bit, some of these pictures I've used, but you may have seen Colombo, and what I hope you'll hold in mind, that this is the type of approach we want you to appear and take, which is a lower power position. We don't want you to be a Mr. Fix-It, ready to solve everything. You're wanting to elicit this change talk from the individual with an eating disorder. Very important to be kind and patient and persistent. And you're trying to help the individual themselves generate their own arguments for change, and when they're ready to think of a change plan. And we don't want you to be like Nurse Ratched, perhaps arguing and challenging or judging, warning of negative consequences all the time, trying to persuade with logic, um, thinking of reasons for defensiveness, confronting with authority or using sarcasm, and giving lots of advice or confrontation. So those are the things we're not doing, whereas we're taking this low power position. So the next step is to understand how starvation can have a problem, particularly on social functioning, which really can make the task of being supporter difficult. And obviously, starvation has big consequences on the brain and body, the structure and function. And one of the most metabolically active organs is the brain. It needs, 300 to 500 kilocalories a day. And so it's not surprising that when we have now got scans and highly detailed information on the brain in anorexia, we see that there is changes to the structure. You can see that the cortical size is reduced by over 6%. And if we look at what that is in dementia, it's 12%, but schizophrenia is 2%. So it's quite a marked reduction. But the good news is that once people gain weight, it does reverse. So it's a compensatory mechanism for starvation. And the figure to the right shows all areas of the brain are reduced. But this causes problems in brain function. And we, alongside our ape and cousins, are very much social animals. And so our brains are wired up to be social. And so one of the things that we lose if we are starving and less brain function is social activity. And as this sort of a picture implies. And so systematic reviews have shown that there are problems with emotional regulation and awareness and various aspects of social functioning that I'm going to talk about. So these just show some experiments that we've done over time, and we've examined various aspects of social functioning. So looking at the attention to threatening faces versus smiling faces. And it might be interesting to think how long it's taken you to find the smiling face in amongst this array of faces. But this array, the people with anorexia have their attention focused on threat, so they see a world rather like this, rather than being able to notice the more positive, that is the more of the norm. And also, not only do they attend to the negative, but they tend to interpret things negatively. And social communication through the face is inhibited. So it tends to be this rather blank expression as shown in this picture by Elise, this mask-like cover with the anorexia inside. But occasionally you do get some people who have this sort of mask of a pleasing face, as though nothing's wrong too. So the two can vary. And having a blank, non-expressive face does interfere with social communication. So talking about this to one patient, sort of, and these secondary effects, sort of asked whether she'd noticed anything like this, and she said, yes, I was known as the ice queen at university. And she also, that was by her peers, but she also noted that her tutors would get rather annoyed with her in tutorials for when they gave feedback, because she seemed sort of blank, and they interpreted it as though she didn't care about their opinion. And she recognized that they didn't know what was going on inside and made this difficult. And so it is well known that this lack of emotional expression does have quite a marked disruptive effect on interpersonal relationships. So, studies in which people are asked to be stooges and to have a role where they're having a sort of poker face in a conversation, you find that people don't like such an individual, and also they have a raised blood pressure after trying to get a conversation with such a person. And if you want to look up other examples of this, there's a very nice example in infancy with called the still face paradigm, and you can just look this up, and you'll see the marked impact and distress that a tiny child has if the mother puts on a blank face. And of course, we know that the uncanny valley effect, if you've got somebody, an avatar that's almost human but not quite, without an emotional present, that gives a sense of disgust and disquiet to us. So all of these factors really make social signaling very confusing. Um, so we've got this blank deadpan face with this reduced expressivity that we found in several experiments. We've got the body that is screaming for help. And we've also got, at times, we hear the anorexic voice, when we try and help with feeding, etc. So we're getting many mixed messages, which can be very confusing. We've also done studies of people of analysing social situations, and we find that they have difficulty detecting intimacy and closeness. They respond coldly to warm feedback, and they come up with solutions to social problems that are less appropriate. So this problem with social functioning affects many domains. And you've probably all experienced these sort of thinking uh, aspects that make life rather difficult. So the alienation and the sort of being deceitful, manipulative, lying, that can be part of the eating disorder, or the paranoid thinking that everybody is me is getting at them. They overanalyze what people are saying. They may have a hidden motive, and thinking that other people are judging them. So we have all of these types of thinking that are unhelpful. And so this does have a big effect on all supporters, whether we're professionals or family members. And so this made us think about these problems and how often they happen in a team working on an inpatient unit. What are the difficulties that might arise there with these problems? And so I did this report several years ago now, written with people with lived experience, where we talked about how difficult emotional reactions and behavioral reactions on an inpatient unit between the teams and the people with the eating disorders could be very unhelpful. And of course, we then realized that the inpatient unit is not unique, and probably these problems would also occur at home. And so this led to us thinking about these and thinking about how we could help families manage these, because we know that on an inpatient unit we have a lot of supervision and team meetings to discuss all of these things. So perhaps you can think about the problems that you think might happen on a ward with uh, misreading social situations or being misread that can cause type of problems. And as I said, we realize that this might happen in at home too. And so working with uh, groups of parents and sharing some of our research and sharing some of our ideas of what helped and in our therapeutic relationships and trying to share those, we developed some animal metaphors that to describe some of the interpersonal style traps that can easily happen. And of course, these occur, as I say, within therapists as also in family members. So we can have emotional responses that are either too much or too little. So we can get this very high intensity where we call it a jellyfish response, where you're showing your emotions on the surface, and that might lead you to be wafting around perhaps in all sorts of directions and not able to sort of think clearly because you're so overwhelmed by emotion. But the opposite can be where trying to avoid emotions, you be an ostrich, stick your head in the sand. But of course, that has a can be interpreted as not caring and not being involved. But also, the the behaviors that result from these emotions can cause problems. So there can be too much push or too much pull. So there can be a push towards growth and autonomy, sort of with what we call rhino care, or, where you're sort of charging in, or terrier, where you're nagging and giving advice all the time, trying to persuade people to change their beliefs and their behaviors. Or you can be trying to protect, being overprotective, giving rather like kangaroo care, and giving and accommodating to the disorder or reassuring, um, which can have problems I'm going to be talking about later. And this often happens when the family members are very anxious. They may be drawn into trying to ameliorate the anxiety. It's a normal parenting reaction, but when it's carried on too long and too intensely in this situation, it can be harmful. So these type of emotional reactions that are very natural and occur in everybody um, can be problematic with in this situation. So I've talked about having too much anxiety leading to accommodating to the eating disorder, or getting trying to be directive, to be Mr. Fix-It, for example, can be frustrating and can fragment support. So these are just some images that perhaps help you think about accommodating behavior, because accommodating behavior doesn't just occur in eating disorders, it occurs in anxiety disorders and in obsessive compulsive disorders as well. And in fact, the cartoon, I don't know how many of you know that, but Fred is obviously an OCD person who we have cartoons about, and you can see his wife Pauline preparing his sandwich to meet EU regulations. We don't have the contamination fears as much in eating disorders, but we'll have the amount of calorie fears would be impacting on the kitchen. And a lot of the storage and cooking of food gets impacted too. But of course, over time, this can lead to the eating disorder sort of controlling all the rest of the house, as you can see by this cartoon drawn by Elise. But another problem that can arise is that family members can enable the eating disorder, may turn a blind eye and take a lot of the pressure off. So these are the sort of accommodating reactions. And I first heard about it with one mother came and told me that she was having another kitchen made in her house, and asked her why that was. And it was like this one here, nobody could go into the kitchen whilst the person with an eating disorder was in the kitchen, and her son was threatening to leave. He found this so impossible, and so her solution was to build another kitchen. So we see the checking of ingredients. It might have to have different crockery, different fridges, different um, types of food, um, and asking for reassurance. So there's all sorts of ways, and we were so interested in this that we built a survey for it. And when we give this to people attending our workshops, everybody in the workshop will have accommodated in some way. And it's not surprising, it's a normal thing that we do with illness. We accommodate and look after it. But it's when it rules the family and takes control, it becomes difficult. And we get this vicious circle. So it's the starvation, it makes the family very concerned, and so they can make exceptions for the anorexia. And they're walking on, everybody's walking on eggshells with anxiety and sort of kowtow to the eating disorder behaviors and don't challenge them. Uh, and this just allows the anorexic symptoms to increase, and so that these become more embedded in family life and become much stronger. And so you've got a vicious circle built up where you can get people accommodating so that they don't eat meals together until perhaps midnight, because that's what the person with anorexia only feels she can tolerate. So you get very extreme accommodation. The other aspect is turning a blind eye. And this, as you can see, that the family take a lot of the strain of the illness, so that the individual themselves perhaps doesn't see and experience some of the negative effects. So the mother may clean up the mess in the kitchen and the bathroom, and cover up for lost food or money. But of course, that this can, taking away these negative consequences, can just allow the behaviours to sort of carry on without any barriers to them. So this is just some examples of these sorts of behaviours, sort of going down to the kitchen and there's no food for breakfast for the others. So the mother would go and drive to the supermarket so that others could have breakfast. The person, her car was out of action, so driving to the supermarket at 11 to take her to somewhere where perhaps neighbours wouldn't see, rather than a local shop. Turning a blind eye to taking money for food, etc. So these types of behaviours can occur, particularly in bulimia, but also anorexia in other ways. And then other patterns of behaviour that tend to occur more with partners or with siblings is type of calibration and competition. So, that you have to eat, your daughter perhaps will insist that you eat a meal with her and will only eat as much as you eat. So even if you're going out, you have to still eat the meal with her. May get cross if you buy foods that she thinks are her foods, sort of melons, the family can't have those because those are what she eats. Or she might buy very tasty, luxurious foods such as cream cakes and put them in the fridge for everybody or prepare them. Or um, uh, uh, giving money to the younger sibling to go to the tuck shop at school, or making sure that chocolates, etc., are on display for siblings, or making sure she does twice the amount of exercise. And it's very important, we've found, that all the family need to be involved in understanding these traps that can be set up. Because if there's mixed responses, so just a small amount of accommodating in other family members can keep the illness going. So it's very important that the family work together to try and modify these type of behaviors. And it's a very common, because it's very hard, and we know this because it happens on inpatient units, that often you get division between team members because one will have more of a sort of rhino type of response, wanting to get change and move people on, and other members may be more anxious and more overprotective. And so it's very common for there can to be a bit of divide and rule within a family. And of course, um, we know that this can make interventions not work, and so they might be and you know encouraged by the person with an eating disorder. And so one of the final, well, there's probably going to be even more metaphors, but a surprising metaphor that a carer came up at one of our carer conferences, were talking about we need to be elephants. And I thought that was rather strange, but what she meant was this head, trunk to tail family approach, where everybody sort of tries to protect little ones if they run into trouble. And so to emphasize the teamwork and how essential that is within families and between families and professional supporters. So this is another vicious circle that can get set up where families and teams get fragmented. Um, so this these effects of the starved anorexia mode and also the disturbed social cognition leads to these interactions of either accommodating or trying to be just persuade with logic, and then we're getting all these tricking, cheating behaviors that come back, and these tend to split up the family. And for the individual, her only friend is the anorexic voice, and she becomes more isolated. So sometimes carers are sort of are rather surprised and perhaps a bit shocked and a bit surprised when we say that probably one of the first things that it's helpful to do is to think about how we can change as inpatient team or parents. And this quote by Viktor Frankl is very helpful, that to think about that when we're no longer able to change a situation, we have to change ourselves. And so these are the sort of essence of what we include in our skills training. And so there are sort of 3 steps. So the first step is how everybody can work together. And this working together requires a shared understanding and ideally sharing some of the skills of being an emotional coach and understanding mixed feelings about change and how with motivation work you can look at these mixed feelings. Then the next step, so that's considering these risk and maintaining factors and considering the consequences of starvation on the brain. But the next step is to consider the impact of the eating disorders on everybody else, because they do have these marked social effects that can trap people. So learning how to regulate our own emotion, uh, and care for ourselves, and not to get into accommodating overprotective behaviours, uh, or behaviours where we become rather authoritarian, which, as I say, it occurs with all of us as therapists. We can get into these traps ourselves, and that's why we have supervision to look at these. And so that's important. And then also, we need to provide the skills for change, and that involves a lot of compassion. We've got to overcome all these barriers to normal social function that are there, caused by starvation and these secondary effects on ourselves, and uh, have compassion and empathy. And then we need to use the skills of motivational interviewing and emotional focus therapy to be able to listen out for and help behavior change. So, as Judy mentioned, a secret weapon that's been very involved in this has been the support and cooperation of people with lived experience. So, we've been developing these skills sharing approaches with people, with carers. Uh, so there's Charlotte, who was very keen on us finding uh, about genetic factors, which have blossomed now, of course, and she's one of the many who've been fighting for this. Pam MacDonald, who worked with us to do a PhD as well, Jenny Langley, who runs these skills training, and Grania, who came down from Aberdeen to our workshops and then wrote one of our first books with us. And Elise, who at the end, who has done all of these lovely diagrams. And so we've got a lot of we've been able to work with people with lived experience to write guidelines and make videos that can help. And we think that this is very important, that we have this evidence-based resource that is for and by patients and carers themselves. And I think that this has been a very useful way of working. And so these are just to thank some of the people I have worked with over time developing these ideas, because we've been doing this for 20, almost 30 years now. And so these are just a small cross section of people who've been involved. So that's the end of my presentation. So perhaps there is time for some questions.
Thank you very much, Professor Treasure, for this very interesting presentation, which I'm sure is extremely helpful to a lot of parents who are here with us today. I would like to encourage people to put their questions in the chat feature. I'm going to start with some of the questions that we already have. With your extensive research and experience, to what extent do you believe that diagnosed and undiagnosed autism in girls is a very important fact in anorexia in a large part of the population?
Well, there is no doubt that there is comorbidity to a degree, but also there is a sort of pseudo autism, because some of the features I was describing with this problem, starvation produced problem in social communication, can very much um, resemble autism. So some, work we've done when we've looked at adolescents and looked at used some of the best screening measures, we don't get very high levels of comorbidity. It's 5%. Whereas if we look at adults, we get a much higher percentage in our inpatient units. And so part of this may be because those who do have this comorbidity perhaps persist longer. So that's one hypothesis. But there's another hypothesis is that there is the starved brain develops many autistic features too. So one of the problems is that it's very taxing to make a good diagnosis of autism. As probably everybody knows, you need to get a history from the parents, and people haven't totally recognized in the instruments how it presents differently in females. So that can be a bit of a problem. So it's still uncertain, but there's no doubt, and there is no doubt that there is comorbidity there, and that, as with all comorbidities, such as with diabetes, we might need to change our approach. And I've got a colleague, Kate Chanchuria, who's been working extremely diligently on looking at a different care pathway, the peace pathway, that might be more appropriate for this group of patients too.
And a follow-up question to that by the same person is, how do you adapt FBT to accommodate young people who like to over-control? Autism can be seen as a friend and anorexia is a bully, but there is an overlap and a starved brain accentuates these traits.
So I almost think that that question is perhaps agreeing with what I'd said, but am I missing a point?
No, just the part specifically about that adaptation of FBT. If you have anything specific that you can enlighten this parent of how to adapt FBT for someone with autism.
Well, I think you do need to, if autism is diagnosed, you might need to make changes to the care pathway and some of your approaches that you might use. I mean, for instance, on our ward in this peace pathway, we we allow a different diet, perhaps without foods that might have textures and smells or things that might impact on the sensory sensitivities of somebody with autism. And we also have changed the decor on our inpatient unit so that it isn't too again overwhelming for people with sensory specificities. So I think it's useful to make these accommodations and realizing that perhaps group approaches might not be as helpful in this situation. But I think this is still work in progress, and I think Kate would say this. What I'm very delighted with is the work that has developed from looking at diabetes and an eating disorder, and this work has been involved, this been in co-production, it's been evidence-based co-design, having professionals from diabetic units, from eating disorder units, and patients all working together, thinking, what is the toolkit that we need for this particular mix? And we're probably going to have to do that if there's others different comorbidities, which we know there are in eating disorders. So I don't think you can have just one. We're going to have to personalize care uh, and make adaptations. I mean, there's no doubt that that our overall aim is to get people to eat, but we might make some accommodations, even though I'm saying, well, beware accommodations for different comorbidities like autism. Does that make sense?
Yes, thank you. Next question. Did clinical presentation of eating disorders in adolescents change somewhat during COVID-19? What I mean is, did doctors observe unusual presentations that do not fully fit classical pictures of well-defined clinical entities, such as anorexia nervosa, And was it more frequent during the pandemic?
Well, I think I mean, we don't fully know, but we only know what got counted easily. Uh, Whereas perhaps some of the more atypical presentations didn't get counted, they didn't come to clinical. But what we did see was a big rise in young patients with quite severe anorexia needing hospital treatment in countries all over the world. So that rise did definitely occur, and it's possible that there will be uh, more unusual presentations that don't come for medical care. So we tend to be biased only knowing those that came to care as easily.
And my own curious question about that, do you think that people presented more seriously because the wait list for treatment was longer? So by the time they got into treatment, they needed a higher level of care? Was that part of this whole hospitalization?
That's a possible explanation, but unfortunately, we know that often there are delays in people coming to care. Anyway, we know that for young emerging adults, it can be 3 years before they come into care. For younger adolescents, it tends to be shorter because it's often parents who are able to activate getting care. But you're right, the duration of untreated illness can be a problem, and I'm sure that had a little bit of a role, but it's very difficult to know, to think that it was the total explanation, because when I suppose yeah, yes, I don't know, we'd have to see over time. Yeah.
Okay, this is not a question per se. Someone commented, I'm noticing that my daughter is very sensitive to my comments about eating. She feels that I'm always watching and monitoring her, that I treat her very differently from other family members, and that is uncomfortable to the point of her wanting to push back and push me away in other areas of her life. Sorry, when in other areas of her life, she is embracing recovery well. She is claiming that I am the thing that is holding her recovery back. So I think this parent just wants some insight as to how you would respond to that type of attitude.
Yes, well, it's very difficult to know, to move from when you're having to give a large amount of support and care about eating to when you can step back. I mean, we always talk about baby footsteps, making small experiments of, you know, uh, and also being able to negotiate over time. And so, with the approach of taking a low power approach, you can say, well, maybe I am making a mistake, and that I'm too, overprotective, and I've that's what I'm very. I've been very frightened over time, and I felt I needed to. Uh, we could make an experiment where I'd try hard to reduce my vigilance, but we need to make sure that we're not losing ground if we do that. So, how will we monitor that? So, come to some joint plan. But I think it's helpful that over time you're able to get some experiments that allow changes in these behaviors.
Thank you. Another question just came in. At what point do you stop using skills for change when the anorexia person's health declines? My daughter's brain doesn't resonate that her health is in jeopardy. She exercises all day to allow herself to eat. She's too sick for programs, yet the hospital won't admit her. We are waiting for a medical emergency to occur for help.
Mm. Yes, that's a very difficult situation, and we always have to have that backstop, don't we? But it is a shame that it can't be arrested before that. But sometimes, you saw on that Elise, she had 5 admissions. Um, So sometimes that does happen. Change takes a while, and people, I mean, people often tell us, don't lose hope. We're listening to what you say, even though we perhaps can't use it at the moment. So we know that for some people, it becomes very severe and is very difficult to manage, and they need the extra support. Um, but but it's important that that we still stay there and are willing to help them.
So you basically saying that we keep using the skills, meaning even if we're not sure that they are working, even if we're not getting a response or feedback, we keep using them.
Yeah, yes, because those skills of kindness and empathy get remembered and internalized. And yes, it sometimes does take a lot of time.
Thank you. Um, well, we don't have any more questions and we pretty much run out of time. So that's a perfect coinciding of the two. I would like to thank you so much, Professor Treasure, for joining us today. We really, truly appreciate it. And I would also just like to tell everyone here, F.E.A.S.T is funded solely from donations from our own community. So if you can give something to support programs like this so we can continue running them in the future, please go to our donations page and give what you can. And I would also just like to let you know about our next webinar next month. It is going to take place on August 10th at noon Eastern Time by Dr. Aaron Parks. And the topic is how to talk to your child when the eating disorder has you walking on eggshells. I'm sure it's going to be a fascinating webinar. I really hope that you all join us. Thank you all so much for joining us today. Thank you again, Professor Treasure, and have a good day, good evening, whatever time zone you're in. Enjoy it. Goodbye.
Thank you, Judy. Thank you very much for inviting me. Bye bye.